Dr. McClure, welcome. We're here at ASCRS 2025.
Yes.
Enjoying San Diego. It's been beautiful.
Yes, gorgeous.
So, as a colorectal surgeon, I mean, obviously this is the big conference of the year. What has been the highlights to you so far? What's been the focus that you really enjoyed listening or talking about?
I mean, there's so many. I love being able to see everybody networking, figuring out how everyone's doing things differently and what I can take home. I think the rectal cancer pieces have been really amazing. Just the research that's going on with regards to rectal cancer, with regards to organ preservation. In the past, people have thought, oh, well, we have to operate, you're going to have to lose your rectum if you have rectal cancer. And now with watch and wait, TNT, TAMIS options, we have lots of different options to help patients keep their rectums, but also be cancer-free. And so we continue to have, just looking at research along those lines and learning what other people are doing and bettering patient care because of it. So feel grateful to be part of that.
You said the words watch and wait
Yeah.
and rectal cancer. You're going to have to dive deeper into that.
Absolutely. So watch and wait. So previously before, the algorithm was that you get chemotherapy, you get radiation, and then you typically get surgery. And so now what we're finding is that if we do chemotherapy and radiation, and then we do another course of basically chemotherapy, then a lot of these tumors, over 40% are actually going away. And so then we put the patients into what we consider watch and wait, where then they're on a pathway where every 3 months, we follow them to make sure that tumor is not coming back with a series of testing. And so a lot of those patients will stay cancer-free having kept their rectums. The other thing that happens sometimes is we'll have small little areas in the rectum that will look like, is this cancer left or is it not? And so sometimes we can do procedures like TAMIS or things like that to remove that small little piece and get a bigger biopsy to see if they too can continue on the pathway where they get to save their rectums. So we call that organ preservation treatment. So that's one of the things that's been very different in the past. If you got rectal cancer, you were definitely getting a surgery, and now in over 50% of patients, that's not happening anymore. And so they're able to keep their rectums, they're able to not have a colostomy bag, and they're also able to get through chemotherapy, radiation therapy, and then return to normal lives.
My mouth just dropped. Almost 50% aren't requiring surgery now.
Correct.
And when you say TAMIS, I think since the time I got out into practice till now, I just heard TAMIS for the first time like 18 months ago. Of course, Mark Solomon, I talked to him, and he's, what does that mean?
Yeah.
And can you kind of explain to the general surgery population how TAMIS is done?
Absolutely.
Why it was developed?
Yes. So TAMIS is transanal minimally invasive surgery, and there's a lot of different ways to do it. So that's kind of an umbrella. How you complete that is a little bit different, and there's a little bit of idiosyncrasies with it. So one of them is you can do a laparoscopic TAMIS. You can do what's called a TEMS, or a transanal excisional microsurgery. Those are all different ways to say you're doing the same thing. A lot of us use robotics to actually do a TAMIS. And so when you think about that, we're doing transanal surgery. So we're going through the anus, we're docking the robot, and then we're actually removing tissue through the anus. So we're not removing anything through the belly, and we're removing the tissue with the robot through the anus. So that's what's considered a TAMIS. So we use that a lot when we have large polyps in the anus that we typically couldn't remove in other ways, or if we have an early cancer, or if we need a big biopsy. So typically we'll go through the procedure itself. We'll basically dilate up the anus, we'll go through the anus, we'll place a Alexis retractor or something of the such that basically helps open the anal canal. We then insufflate to give ourselves pneumorectum, like we do typically laparoscopically or robotically, and then we'll dock the robot through the anal canal using one of the gel ports, and then we're able to operate in small spaces, which is wonderful. As you can imagine, the anal canal is not very big. You have much less room in the anal canal than you do in the abdomen. So we're looking at actually SP, Da Vinci SP has just been FDA approved for transanal and transabdominal as well. So that is a robot that you can actually dock in one site, and then you have these arms that come out, and they actually allow you to get much more space within the anal canal. And so basically we're doing surgery through the anal canal and without anything in the abdomen, and patients are doing extremely well and going home either the same day or next day. The benefit for the patient is that those patients are not having to get a full resection. So they're not having to have the part of their colon or rectum taken out and then re-anastomosed or reconnected, and they're not needing a bag or an ostomy, which is one of the things that significantly affects patients' life after treatment.
Well, heck, I mean, just the risk of that anastomosis. I mean, by removing that surgical risk and and everything that's associated with it. That's massive.
And patients who have rectal cancer, they oftentimes will get what's called low anterior resection syndrome, because you're stapling or you're doing that anastomosis right on top of the levator complex. And that's the complex that tells you have an internal anal sphincter, an external anal sphincter, and then you have your pelvic floor. And so the whole job of your internal anal sphincter is to say, do I need to have a bowel movement? When do I have it, and what kind is coming? How much time do I have before this is happening? And so oftentimes for patients that have had that connection, that a new anastomosis and have had to have surgery, they will have the low anterior resection syndrome because that's right on top of the anal canal. And so they oftentimes will get the feeling like they always have to have a bowel movement. They'll have throughout the day, some of the patient complaints are that they have to always know where a bathroom is. They have to make sure that sometimes they can have fecal incontinence or they can have accidents. And so those things go away when you're not having to do that anastomosis. And so really these technologies that we're talking about are changing the face of how we do surgery for patients and for surgeons.
How do you differentiate who's a candidate for TAMIS and who still requires an old resection?
So typically most patients, so either when you come in, you'll get staged for rectal cancer. So when you get staged, you'll get stage T1, or we talk about staging in three different, we talk about the mucosal staging, so the T stage, how far has it gone through the wall, N, the nodal status, and then M, has the cancer gone anywhere else? And so if you're a stage 1 where you have had, it really is only in the wall, and if it's a T1, I would say, T1, which is of stage 1, those patients are candidates for having a TAMIS because the rectal cancer is only in the very first layer, has not gone to the lymph nodes, has not gone to anywhere else. So T1s, we oftentimes will treat surgery up front, not chemo and radiation. If they're a T2, that's a little bit more questionable, and so oftentimes we'll offer surgery up front, but with the TAMIS and the things that we're doing now, that does potentially allow us to offer that to patients a little bit earlier. Most rectal cancers are in the they're in the stage 3 or stage 4, and so that so we'll talk about stage 3 for the purposes of this. It's invaded deep enough through the walls that we need to do something, but also there's some lymph nodes involved. Almost always there's some lymph nodes involved because that's how rectal cancer works. And so in those patients, they'll oftentimes go through what's called TNT, or a total neoadjuvant therapy, and so they'll get chemoradiation and chemotherapy, and then they'll get restaged. Once they get restaged, if they've had complete resolution, we'll oftentimes put them in what we consider the watch and wait category, or let's give you a chance to make sure that we're able to kind of watch as we go along and let the cancer, hopefully you'll stay cancer free, which a lot of patients do. Or some of those patients their cancer has not responded completely or not enough that we're comfortable waiting. And those are the patients that would need the full surgery that we're just talking about. So rectal cancer is one of those things that there's some black and white, but a lot of gray. And so the best thing you should really do is talk to your doctor about what options there are, and we can kind of go through that as far as what and why, keeping you safe along the way.
And when you're staging, we're using MRI, ultrasound, does it matter?
So typically we use MRI. The data shows that the MRI is better, just because if it's a low rectal lesion and it's really early, sometimes we'll use ultrasound, but typically most centers are going to MRI now. Because you can see all the different layers and it's really great for soft tissue. The other thing I will say is sometimes you have cancer in a polyp, but you don't actually have it going anywhere else. And so those patients are really great options for TAMIS or for transanal surgery, because we just need to be able to get in there, get it all out with margins, and then really get a big biopsy to pathology and then figure out what to do next. There are some of our GI colleagues that can do some of this endoscopically, so they will also do endoscopic mucosal resection and things like that. But for the bigger polyps and whenever it comes to cancer, that gets deferred to colorectal surgery.
What's the adoption been like for TAMIS in terms of, I assume it's not universal yet.
No, right. And so you really have to have the skill set, the technology, and also the desire and to kind of go down that pathway. High volume centers that are doing high volume robotic surgery, oftentimes you're doing TAMISs. Most colorectal surgeons are doing TAMISs, but not all. It just depends on what they've done for training. And then you really want to look for centers of accreditation. So the NAPRC centers for accreditation, that's our rectal cancer kind of our guidelines. We follow those. Most NAPRC centers will allow you options to get a TAMIS in it's somewhere within their facility or within their regional structure for cancer.
I mean, listening to you though, I find it tough to argue you shouldn't be sending patients that are potentially TAMIS candidates to somebody that can do it at this point.
Absolutely. I would always recommend, if it's an early cancer, if it's a big polyp, if it's something we don't know is cancer, or it's a follow-up where you have a little bit of cancer left after you've done your complete treatment, and there's a possibility that you could get rid of that, and that's the only site. In some of the trials, we're actually looking at removing those and then letting them continue on the watch and wait pathway. So it is just a game changer for what we've been able to do from a patient satisfaction standpoint. Also ensuring that the patient, number one, always safety. We want to keep them healthy and cancer-free for as long as possible. But the fact that we're able to do these things, the TAMIS procedure, without having them to give up their quality of life, that's been amazing for us and for the patients.
And when you're following them post, let's say they've had the neoadjuvant, and now, is it still MRIs? Is that how you're doing it?
Yeah, they're getting MRIs every 3 months.
3 months.
They're going to get a FlexSig every 3 months because we want to make sure that we stay on top of it. These cancers luckily are slow growing, so I think some of the concern in the meantime is, oh my gosh, what if it's not resected? Is it going to grow faster? Is it going to travel? Typically that's not the case. So we are watching them every 3 months. They'll get presented at our tumor board, so all the radiologist, the oncologist, the surgeon will all discuss the case and decide what's best for that patient. But we are watching them very closely, and we do have recurrences, but typically it's something that we're able to handle.
I think I always worry anytime I see this that the neoadjuvant killed the cells they'll react to it, and then whatever does residual, if you do have residual cells, they're not going to be as responsive. Are we seeing anything like that? We
are seeing in some studies that if you recur after a procedure or after watch and wait, you are seeing sometimes it's happening where it's either recurring in the liver or the lung, right? Those cells have kind of gotten out of I call it the barn. If you take care of the barn, which is the colon cancer or the rectal cancer or whatever it is, the barn's gone, but you still don't know if there's horses wandering out in the other places. Though the barn is not what's going to end up being the problem, it's actually other places. So we do see some migration of that. It happens in a small percentage of patients. But I would tell you that we also are developing circulating tumor DNA. We're looking at a lot of other testing to be on top of that to know if there are cancer cells in other places that they're not supposed to be. So you would want to make sure that you have negative circulating tumor DNA, and that we see all of those positive things for treatment. As cancer cells, as you give TNT and things like that, we are seeing some cancer cells are not responsive, but typically most of them are the same kind that were there the first time. So I think once we realize that if those cancer cells have mutations or aren't responding the way, then we switch protocols quickly and go into one of the second or third line protocols to be able to treat them, which has been proven through research to usually work.
And besides this field, you're also a huge, let's say, fanatic when it comes to acute use of the robot.
Yes.
So being minimally invasive in emergency settings,
yes.
And you're a huge fan of 24/7 access.
Yes.
What are you seeing, and why are you such a proponent of this?
So in the United States, 40% of colons are still done open. 40%, that's a lot. When I think about 98% of my colons are done minimally invasively, and that's the same in my entire group, right? So when I think about 40% of colons being done open, that is a significant amount of colons that it's morbidity for the patient. We understand, anastomotic leaks, cost to the system. And so a lot of the work that we have to do is really within that perforated acute patient. And so there's been a lot of thoughts previously that you can't use robotic technology, or you can't use the robot for perforations, you can't use it in an acute setting, but there's data that shows you absolutely can. And so, for example, in our hospital, if a patient comes in, they're perforated, they have to go to no matter if it's colon, if it's gallbladder, if it's appendix, if it's small bowel, they're going to go to the operating room and they're going to have an attempted minimally invasive procedure. And so we really should be allowing that for all patients. And so we have a lot of work to do in that realm. A lot of it is first of all, is making sure the surgeons know that it is possible and safe, because number one, we never want to hurt our patients, right? So there's data that shows that it's absolutely possible, it's absolutely safe, and we're doing it. So that's important. Really getting the culture of your hospital on board, understanding the why it's important, that it really shouldn't matter what time of day it is. to what type of surgery the patient gets, right? So that's where the 24/7 access comes in. In some hospitals, they have surgeons that are trained robotically, and at 7 in the morning, they can take that patient for a robotic sigmoid, but in 2 in the morning, they will get booked for an exploratory laparotomy or a maximally invasive incision. And that we really need to change that equity for our patients, because it really shouldn't matter what time of day you come in as to what surgery you get. We know that the negative effects for patients from after an exploratory laparotomy are ileus, hernia rate, they stay in the hospital much longer, increased pain control. I would not want an open operation, and so I should be able to offer the same type of operation to any of our patients. So the job we have is to train the surgeons that it's safe, to give them the technology and make sure they have access to it, to help them maneuver through that their specific hospitals and barriers with staffing and things like that, to get 24/7 access, and then to really continue until that 40% is closer to 5 to 10. We understand that at all times you're going to have some open procedures. That's not the negative. The negative is that we need to do better for our patients.
I'll be honest, if you'd have told me 10 years ago we would get to 60% colorectal cases being done minimally invasive, that would have blown my mind. Like it definitely is improving.
Absolutely.
But they're so difficult. I mean, from a learning curve, they're definitely difficult.
Yeah.
I'm glad that we have surgeons such as yourself that specialize in this kind of field.
Yeah.
From a general population standpoint, if you're talking to, I would say, like your grandmother's friend, and you said, here's the most amazing thing that the general population really needs to understand about what's going on with colorectal right now that's changing their world, they don't even know it yet, what do you think that would be?
From a patient standpoint, I think from a patient standpoint, it's the minimally invasive options. We are doing so much more minimally invasively. If you have Crohn's disease, if you need a pouch, if you have bad cancers, we're doing all these things minimally invasively. So I think that's the revolution, the minimally invasive revolution that's happening right now. The fact that we're not operating on all of our rectal cancers, that we're able to kind of get them through, and then some of them are able to not need surgery at all. That's the biggest thing. The other thing I would say is we're doing a lot with pelvic floor. So for women and men who have had issues with their pelvic floor, a lot of them are having significant issues with bowel movements and things like that. They have rectal prolapse and things like that, and they've just been living with them, and they don't have to. We have really great minimally invasive options to be able to treat those patients and give them their quality of life back. So that's from a patient standpoint. From a surgeon standpoint, the rectal cancer piece that we talked about earlier, but also the fact that like SP is available now, and that we're going to be able to operate in places that we weren't typically able to operate previously. And polypectomies no longer are going to need huge formal, resections. We're just going to need to remove the polyp, get pathology, and the patient doesn't know, that's potentially like a overnight procedure. So we're really making strides in what we're able to do, and just keeping the patients, using technology to benefit the patient, also to make sure that they're not out for 4 to 6 weeks anymore. They're back at work in 1 to 2, and those are things that with a significantly less complication, like a significant decreased complication profile, and so those are things that we have not been able to do before. And so I'm excited to see where the technology is going, and excited to be a part of it.
Well, I can't thank you enough for your time. Welcome to the Cutting Edge.
Thank
Always
you.
a pleasure to see you.
Same as well.
I hope you enjoy the rest of your time here at ASCRS.
Yes, thank you so much.
Thank
All right,
you.
thank you.